acute respiratory distress syndrome and respiratory failure, multiple organ failure and shock, as well as venous and arterial thromboembolism. Today's conference is attended by prominent scientists, opinion leaders who are involved in the development of the main guidelines for the management of patients with the COVID-19, and who directly study and research the pathogenesis of both COVID-19 and post-vaccination syndrome. It is with great pleasure I would like to introduce our guests. Professor Ismail El-Alami, the president of the French Society of Angiology, France. Professor Alex Spiropoulos, system director of anticoagulation and clinical thrombosis services, the United States. Professor Sam Schulman, vice president of the International Society on Thrombosis and Hemostasis, Canada. Professor Jean-Christophe Gris, head of the Hemostasis Pathology Laboratory, president of the Medical Administrative Department for Clinical Studies and Innovation, France. Professor Jihan Ai, Medical University of Vienna, Austria. Professor Benjamin Brenner, Technical Ruth and Bruce Rappaport Faculty of Medicine, Haifa, Israel. And finally, our country is presented by academician Russian Academy of Sciences, Professor Alexander Makatsary, head of the Department of Obstetrics and Gynecology, the Filatov Clinical Institute of Children's Health, Sechenov Institute, Russia. Professor Victoria Bisadze, Russian Academy of Sciences, Professor Jamila Khizroeva, Russian Academy of Sciences, Russia. Dear colleagues, we can start now. The scientific part of our conference opens with the report of Professor Ismail El-Alami, Thrombosis in the COVID-19. Please, Professor.
Thank you, Mr. Chairman. I'm honored and grateful to the organizing committee for inviting me to share with you this important topic on thrombosis in COVID-19, which is based on a challenging incendiary duality, inflammation and coagulation. COVID-19 is the respiratory viral infection caused by the coronavirus SARS-CoV-2 for severe acute respiratory syndrome coronavirus 2. But regarding SARS-CoV-2 invasion, depending on ACE2 receptors, you see that these receptors are present in many organs and on many cells, leading to multifocal invasion and a systemic reaction. The dysfunctional immune response is related to an excessive cell infiltration of monocytes, macrophages. So, there is need for chasing the cytokine storm in link with this excessive inflammatory response, leading to overwhelming complement and coagulation cascade activation, promoting thrombi formation, oxidative stress and tissue damage, and multi-organ failure. You see that coagulation and inflammation is a pleonasm. Intrinsic or contact phase activation of the coagulation cascade with factor XII is associated with complement activation and bradykinin formation, leading to both edema and inflammation. Factor XII stimulates dendritic cells involved in cytokine production and T cells modulation. Fibrinogen, as a mediator of inflammation, acts on different cells through integrins on non-integrin receptors to induce pro-inflammatory effects such as NF-kappa B activation or TNF-alpha or IL-1B release. Release of polyphosphates regulates intracellular mechanisms related to metabolism, signaling or apoptosis, and also extracellular pathways to activate coagulation to generate bradykinin, leading to vascular permeability and inflammation. SARS-CoV-2, inflammation, and coagulation are a deleterious trio promoting thrombosis. You see that viral pathogens or damage-associated molecular patterns and cytokines trigger monocyte activation with tissue factor exposure, monocytes recruitment to endothelial cells with a more adhesive vascular wall, with von Willebrand factor, selectin, and collagen involvement, thrombin generation, and platelet aggregation in the vascular compartment. Neutrophils recruitment by activated endothelial cells and release of nets amplify blood clotting, with a decrease of endogenous anticoagulant pathways such as TFPI and antithrombin. Direct injury of endothelial cells by the virus with activation of the coagulation cascade. Recruited neutrophils release nets, neutrophils, extracellular traps. You see that, like an excited llama, neutrophils spit out their chromatin and build a fibril network trapping not only bacteria for phagocytosis, but also platelets for thrombogenesis. So, added to fibrin and von Willebrand factor, it's a third thrombus growth support called netosis, based on both inflammation and coagulation. Nets with toxic histones activate the contact pathway for clot formation with the release of polyphosphates, help with von Willebrand factor to platelet recruitment and aggregation, inactivate natural anticoagulants such as TFPI or thrombomodulin, and promote fibrin generation, which is resistant to natural fibrinolysis. Particularly elevated levels of nets were found in the blood of COVID-19 patients diagnosed with at least one thrombotic event. You see that in this case-control study, nets in patient sera were associated with a higher risk for thrombotic event in spite of thromboprophylaxis. You see that SARS-CoV-2 may use different membrane receptors to interact with platelets. The consequences of pathological platelet hyperactivation are summarized here, with increase of platelets microvesicle and granule release, with the cytokine and chemokine release with platelet-bound neutrophils, platelet aggregation, and platelet apoptosis, leading to both thrombosis and inflammation. So this hyperplatelet reactivity may contribute to injurious host thromboinflammatory response. It's a multicellular COVID collaboration for such a thromboinflammation involving all the vascular cells such as neutrophils, monocytes, endothelial cells, and of course platelets. Platelets are an interface actor leading to thrombin generation, platelet aggregation, and microparticle spread for prothrombotic status and pro-inflammatory status of COVID-19 patients. Reported COVID-19 associated coagulopathy is quite complex and includes two main axes for activated coagulation and endothelial cells damage, but you see that we got many systems in the vascular compartment involved and cooperating to lead to such tissue damage. A real pulmonary vascular endotheliolitis is reported. Inflammation is increasing the viscosity of the vascular compartment and is provoking a vascular leakage, coagulation, and also a major dysfunction in the alveolar compartment. There are many microthrombi in the interalveolar septa. Erythrocyte extravasation and fibrin network development in the intra-alveolar compartment. So you observe a major endothelial injury with disrupted cell membranes. There is also a real pulmonary induced coagulopathy with extensive microthrombi formation and vascular rupture leading to bleeding in these frail patients. So the ground glass opacities are typical, but this fibrosis is also reported with pulmonary embolism occurrence with a peripheral and segmental and subsegmental thrombosis. Concerning the endothelial injury and COVID-19, you see that the virus entrance into endothelial cells triggers endothelial dysfunction, which is associated with apoptosis and pyroptosis, the release of inflammatory mediators with tissue factor-mediated thrombin generation, and the huge disequilibrium of the hemostatic balance. So keep in mind that COVID-19 is a multidimensional disease based on patient risk factors and comorbidities, such as cancer or sickle cell disease or kidney impairment, and inflammatory response with endothelial dysfunction, leading to hemostatic abnormalities and clinical outcomes such as venous thromboembolism, arterial thrombosis, or disseminated intravascular coagulation. So we must see this problem in 3 dimensions and being a profiler respecting the 3 C's. C for the context. The COVID-19 is more or less severe. C for clinical history with the patient background, which is important. And C for the vascular compartment, which is the ring of this battle with this important interface between plasma and cells. This thromboinflammation is related to COVID-19 severity and progression. So the greater is the stage, the higher is this thrombotic risk based on both disease severity, inflammation, and the hypercoagulopathy. We try to build a COVID-19 coagulopathy staging based not only on the lung damage, but also on some coagulation parameters such as D-dimers, platelet count, PT or APTT prolongation, and fibrinogen increase, for example, and the inflammatory status. And the greater is this staging, and the stronger must be our antithrombotic strategy to try to control this incendiary situation. Our prothrombotic prognosis for COVID-19 is based on an audit, which is related to the context with COVID-19 severity, to the patient-related comorbidities, and to the coagulopathy itself, with this massive inflammation and all factors leading to massive thrombin generation and systemic cell activation in the vascular compartment. We observe more frequently venous thrombosis than arterial thrombosis in COVID-19 patients. But besides this, microvascular thrombosis are also reported with many organ damage. You see that in 4 ICUs experience among 150 patients, we got a very bad surprise. Pulmonary embolism occurred in 17% of patients despite thromboprophylaxis. And comparing ARDS patients, you see that pulmonary embolism is 15-fold more frequent in COVID-19 patients than in non-COVID-19 patients before matching, and still 6-fold more frequent after matching these groups. In other countries, such as here in Netherlands, they observed the same picture with a reported increase of venous thromboembolism reaching 57% at day 25, with mostly PEs in these frail patients. So, in this recent meta-analysis, including around 50 studies and 18,000 patients, you see that VTE is frequently associated with COVID-19 with an incidence of 17%. And this incidence is much higher in ICU settings compared to the conventional wards. VTE is also a worse prognosis marker with an increased mortality. But pay attention that the major bleeding is another issue which is not known in this frail population. It's important to better identify these patients at COVID-19 worsening and VTE risk, because, again, who is at risk for that must be well protected. So various biomarkers are significantly increased and correlated with disease severity. IL-6 for inflammation, von Willebrand factor for endothelial dysfunction, D-dimers for coagulopathy, and PI1 for impaired fibrinolysis. Markers of COVID-19 coagulopathy can be also markers of disease severity and worse prognosis. You see that there is a huge increase of D-dimers and a huge decrease of fibrinogen and antithrombin levels observed in non-survivors compared to survivors. So this disseminated intravascular coagulopathy profile is a marker of worse prognosis. Is the dimer a marker of COVID-19 severity? You know that in fact this parameter is not so specific because it can be related to vascular damage, to pulmonary intravascular coagulopathy, or to a real DAC, and maybe an antithrombotic resistance. And we must use an age-adjusted threshold in these patients. In fact, in a very recent North American multicenter cohort involving around 3,500 patients in ICUs, you see that there is a significant increase of D-dimer levels in these patients at their admission at day 1 or day 2. and higher D-dimers level are independently associated with a greater risk of death, even before or after multivariable adjustment. The ADAM13 von Willebrand factor axis is also important. So this ratio was strongly associated with disease severity, and it's showing the increase of that hypercoagulable state and the increase of risk of microthrombosis in these COVID-19 patients. So the huge von Willebrand factor plasma levels with a reduced clearance is involved in this thromboinflammation. Another parameter is also proposed, such as the increase of extracellular vesicles with tissue factor activity, which this parameter is correlated to the other comorbidities for worsening disease, and it's significantly increased in severe patients or patients with thromboembolic events, showing that there is a real contribution of these microparticles for thrombus growth, and of course contributing to the link of inflammation and thrombosis. Another parameter is also proposed to reflect this angiotensin II mediated endothelial dysfunction. So this soluble FMS-like tyrosine kinase 1 is a decoy receptor acting as a trap for VEGF, and it's known to be, again, a parameter associated with adverse outcomes in preeclampsia. So this parameter could be, let's say, reflect of the endothelial damage in these COVID-19 patients. A global evaluation has been proposed to visualize the hypercoagulable viscoelastic blood clot characteristic in these critical ill patients. You see that you observe a particular profile with a shorter coagulation time, an increased velocity, and a greater maximum clot firmness in these critical ill COVID-19 patients. And that is showing that there is an impaired fibrinolysis in this patient with a prolonged lysis time. COVID-19 associated thrombosis and coagulopathy is based on an intense thromboinflammatory state with multiple cell interactions involving platelets, neutrophils, endothelial cells, a deleterious effect on coagulation and fibrinolytic systems, affecting all the cardiovascular system. So, a better understanding of these complex pathophysiological mechanisms is essential for proposing an efficient treatment. Thinking thrombosis and COVID-19 is thinking on thrombosis and co for cooperation with these multicellular actions, for coagulation with this hypercoagulable inflammation, for the context with the severe clinical staging, comorbidities with many cardiovascular risk factors, for co-craft or co-medications with renal impairment or drug-drug interactions, increasing risk factors for thrombosis. So all these co-factors lead to complications. And now the challenge is to avoid all these complications, and we're going to see with the next speakers how to limit this multifactorial and secondary risk based on a more adapted strategy. Thank you for your attention.
Thank you very much, Professor Elalamy. Are there any questions, colleagues? I think you can ask questions using your YouTube. Dear colleagues, our next speaker is Professor Alex Spiropoulos. Please, Professor.
Thank you very much. I would like to very much thank the conference organizers of this very important topic of COVID-19 and thrombosis, which really reflects the state of global health. And as was said already, represents one of the great challenges of 21st century medicine. I also like to give a word of thanks to all my colleagues worldwide who've spent a lot of efforts in terms of meeting this challenge and better understanding the effects of COVID-19 and coagulopathy. My discussion today will involve specifically thrombosis management in the hospitalized COVID-19 population. And these are my disclosures for the purposes of today's presentation. And by way of introduction, I don't have to remind this group of the ravages and implications of COVID-19 disease globally caused by the SARS-CoV-2 virus. In every epicenter that the virus has hit across the globe, whether it be China, and then Western Europe, then the United States, it has caused great morbidity and subsequent mortality in a reasonable subset of the population. And at one point, the United States was the epicenter in COVID-19 disease. We saw a huge uptake in terms of cases and deaths. And here, again, over 30 million cases and now over 600,000 deaths and counting. And what's important to keep in mind is that thrombotic complications have been associated in up to 60% of these deaths, especially in the elderly and especially in patients with underlying cardiovascular disease. So that subsequent autopsy results have revealed a high incidence of both unsuspected venous thromboembolism or VTE or pulmonary arterial disease. Now, in the pre-COVID era, we knew that hospitalized medically ill patients, including those with pneumonia and sepsis, had been at moderate to high risk of VTE, and we could expect anywhere from a 50 to 60% risk reduction using parenteral agents such as heparins or fondaparinux. We also subsequently and more recently understand that there's a subset, about 25% of medically ill patients that are at high risk of VTE and would likely benefit from a strategy of post-hospital discharge thromboprophylaxis, usually with a direct oral anticoagulant. And lastly, we've had previous experience, if we paid careful attention, with viral pneumonias, especially in the setting of ARDS, and these include the SARS, MERS, and H1N1 viruses that have shown a multifold increased risk for VTE. And low quality data suggested a significant reduction of thrombotic risk using empiric anticoagulant therapy. Now, again, prior to the COVID pandemic, we started to realize that we could use validated clinical risk tools, such as the IMPROVE tool, as I have shown here, and also elevated D-dimers, which Professor Lalamy before me has really come front and center in describing prognostic abilities of both poor outcomes as well as thrombotic risk in these patients. So that in the pre-COVID era, a high IMPROVE score and high elevated and high D-dimer score predicted a higher thrombotic risk populations. And this has special significance in the COVID-19 era. Again, Professor Lalamy gave a very thorough and detailed overview of the complex thrombotic mechanisms and this relatively new entity of thromboinflammation caused by both the coagulopathy and cytokine storm in SARS-CoV-2 pneumonia, really involving viral entry into the alveolar tissue, the development of both cytokine storm as a consequence of complement activation, importantly endothelial cell activation and endotheliolitis, contact system activation, all leading to thrombin generation and a hypercoagulable tendency. And as was discussed also, the various risk factors for thrombosis in SARS-CoV-2 are multifactorial, and they include both patient-related risk factors that we've known in the acutely ill medical patient, patients with advanced age, patients who are relatively immobile, patients with underlying cardiopulmonary disease, cancer, and sepsis. But also importantly, SARS-CoV-2 specific risk factors, mainly due to the marked inflammatory response and subsequent endothelial dysfunction of superinfected individuals. And these include a decrease in tissue factor pathway inhibitor, the presence of lymphopenia, and importantly, marked elevation of inflammatory cytokines, especially interleukin-6. And as was suggested previously, these led to both hemostatic abnormalities and the presence of microvessel thrombotic disease, including the presence of pulmonary microthrombi, intravascular coagulopathy, evidence of myocardial injury, and an elevation in cardiac biomarkers, but also importantly, an elevation in biomarkers that include D-dimers, von Willebrand factors, and other. Also, there's the classic adverse clinical outcomes caused by microvessel thromboembolic disease, such as venous thromboembolism, myocardial infarction, stroke, and to a smaller degree, the presence in about 5 to 10% of patients, classic disseminated intravascular coagulopathy. Now, because of the multifactorial cause of coagulopathy in severe COVID-19 individuals, antithrombotic strategies for this coagulopathy must be multifactorial in nature. And these include the possibility of antiviral effects, preventing membrane fusion and endocytosis of the virus. We see that the potential to reduce inflammation remains, I think, a key antithrombotic strategies, and we've already seen the use of non-specific inflammatory agents such as corticosteroids have a benefit in terms of mortality, especially in very sick, critically ill COVID-19 patients. Unfortunately, more targeted responses such as IL-6 receptor antagonists have not been proved efficacious at present, either as add-on therapy or other modalities, although again, other approaches such as contact pathway activation inhibitors may indeed be of value ultimately, although that remains to be seen. The inhibition of procoagulant factors remains a logical antithrombotic strategy for COVID-19 coagulopathy, whether using antiplatelet agents, which in theory would block, again, platelet-mediated mechanisms of thrombin generation, or agents such as direct oral anticoagulants, which can directly inhibit activated factor 2 or activated factor 10 in COVID coagulopathy. Also, the potential to use more novel agents, such as the contact activation pathway inhibitors, factor 11 and factor 12 inhibitors, remain attractive potential agents. Of course, one can also look at enhancing the body's natural fibrinolytic mechanisms by exogenous fibrinolytic agents. And lastly, as a last pathway, the ability to enhance the body's natural anticoagulant pathways, whether through antithrombin-dependent mechanisms such as using our old friends heparin, lone liquid heparin, fondaparinux, or by other more novel mechanisms such as using activated protein C inhibitors and thrombomodulin-based strategies remain also of potential value. Now, we have a very good sense a year into the pandemic or more, what are some of the key predictors of thrombosis in hospitalized COVID-19 patients? And these include patients with advanced sepsis. As was already mentioned, elevated D-dimers remains a key predictor of both poor outcomes as well as increased thrombotic risk, especially D-dimer levels are greater than 4 times and especially 6 times the upper limit of normal. Patients with advanced age, patients with underlying obesity and underlying cardiovascular morbidity remain at a special risk. And lastly, patients who are critically ill. Indeed, just a few months ago, we have corroborated the early reports coming out of Wuhan, China, that very elevated D-dimers are independent predictors of both thrombosis and poor outcomes, including mortality, in a very large cohort of 9,400 hospitalized COVID-19 patients in a multivariate analysis. Now, we can appreciate the potential for the effect of heparin on mortality in hospitalized patients with severe COVID-19 and coagulopathy. And again, early reports out of China suggested that heparin use was associated with lower mortality risk, especially in those patients with elevated sepsis-induced coagulopathy scores or very elevated D-dimers. And indeed, multiple thrombosis research groups, including ours, found some very unique mechanisms of thrombosis and unique clinical manifestations of thrombotic mechanisms, especially with respect to an increased risk of a venous thromboembolism, representing really a perfect storm of the immune system, inflammatory system, and coagulation system, as has been discussed. And this perfect storm really represented or manifested itself in three somewhat unique clinical findings. The first is the very high prevalence of thrombotic complications, both in hospitalized and importantly in critically ill COVID-19 patients. So that rates of deep vein thrombosis or DVT as high as 46% to as high as 85% were discussed in early reports, although later reports in much larger series of patients, initially in New York area hospitals, reported much lower rates at 6.2%, suggesting the presence, the possibility of overestimation of risk in the earlier smaller studies, and also the possibility of reporting biases. Nevertheless, this rate of symptomatic DVT at 6.2% is about 3 to 5-fold higher than similar historical matched controls in the pre-COVID era. Risk of PE as high as 42% has also been described in this population, which is much less susceptible to bias, and again is up to 3-fold higher compared to historical matched controls. And lastly, the risk of arterial thromboembolism, including stroke and myocardial infarction, has been described in up to 4% of patients. The second manifestation is the very unusual nature of thrombosis in COVID-19 patients. So here on the bottom left, we see evidence of in situ pulmonary thrombosis against a background of ground glass, seen in the severe COVID-19 patient population. And on the right, we see evidence of pulmonary microthrombi with fibrin deposition shown in blue, and also evidence of megakaryocytic deposition as well. But the third most worrisome phenomenon from a clinician's point of view is this phenomenon of breakthrough thrombosis in COVID-19 coagulopathy despite standard thromboprophylaxis. So early reports suggested that despite standard thromboprophylaxis with heparins, confirmed VTE rates as high as 27% were described. As was discussed previously, despite prophylactic or even higher escalated dose anticoagulant therapy, a thrombotic complication rate approaching 17% was described in ARDS patients with COVID-19, which after multivariate analysis was up to a 6-fold higher risk of thrombotic complications compared to, again, non-COVID-19 patients. And in some smaller studies, the suggestion was using systematic screening approaches, a VT prevalence of 100% could be ascertained. So because of these very worrisome early reports, international guidance statements, including both from cardiovascular and thrombosis societies, quickly mobilized. And I think this is a real tribute to these guideline groups to disseminate international guidance statements on COVID-19 and thromboprophylaxis. I was privileged enough to chair the International Society of Thrombosis and Hemostasis guidance document on this topic. So for VT prophylaxis in hospitalized COVID-19 patients, we advocated for routine prophylactic strategies using standard doses of fractionated heparin or low liquid heparin, with low liquid heparin recommended due to once daily dosing and the potential for less drug-drug interactions compared to other agents. And this could be modified to intermediate dose heparin based on key clinical features such as advanced body weight or in the critically ill patient population. And lastly, a consideration for multimodal thromboprophylaxis in key patient groups. We also advocated for a strategy of extended thromboprophylaxis post-hospital discharge with either low liquid heparin or preferably a direct oral anticoagulant for up to 30 days in patients with high risk features. So this slide summarizes both United States and international guidance documents on anticoagulation in patients hospitalized with COVID-19. And here we see the preponderance of evidence, both from societies such as the American College of Cardiology, American Society of Hematology, the CHEST Group, the International Society of Thrombosis and Hemostasis, the National Institute of Health, and the World Health Organization that advocated for the use of universal prophylactic dose heparin in ward patients, and the same for ICU patients, with the potential to advance to an intermediate dose strategy in patients with high-risk features. And at least some of these same guideline bodies advocated for the potential for use of post-discharge thromboprophylactis in COVID-19 patients who are hospitalized with certain high-risk features. For VT treatment and confirmed VTE, one should use therapeutic dose heparins with a length of therapy at a minimum of 3 months. And this represents our early adaptation of a universal VT prophylactic strategy in a very large Northwell system. This represents one of the largest health systems in the United States, of over 23 hospitals and over 2.5 million lives represented. And what we did is we advocated for a much lower threshold for creatinine clearance to give a universal Lovenox or enoxaparin, 40 milligrams once daily to all our hospitalized patients. And for those patients with a BMI greater than 30, we advocated for the use of twice daily enoxaparin, 40 milligrams. Knowing and understanding full well and hoping that the increased heparin exposure using these strategies may lead to a prevention of thromboembolic events in this patient population. Now, I think from the clinical realm, it is this question that remains the most cogent and most important in battling COVID-19 associated coagulopathy. Namely, is exposure to escalated or even treatment dose anticoagulation, does it confer benefits in decreasing the coagulopathy in hospitalized COVID-19 patients? So that early reports suggested that heparin users versus non-users had a mortality advantage, and that therapeutic anticoagulant reduces hospital-based thromboembolic complications by as much as 70% or less. But of course, these represented low-quality experiences, and the only way to definitively answer this question is by the initiation of high-quality randomized trials looking at this key clinical question. At present, there are at least 20 high-quality randomized trials comparing escalated or treatment dose heparin strategies versus standard of care heparin strategies in hospitalized COVID-19 patients. And these include the very large multi-platform trials such as TAC, REMAP, CAP, and ACTIVE, as well as the more moderate-sized trials such as our own HEP-COVID trials that we're conducting in the United States. The study design of all these trials is that of a randomized, open-label, and usually multi-center clinical design. The population includes either ICU, medical ward patients, or both. The intervention for the majority of these clinical trials includes therapeutic dose heparin, mostly low molecular heparin, with the control being mostly standard of care prophylactic dose heparin. And the primary outcomes include combinations of either all-cause mortality with and without organ-free support, or the first two with the addition of major thromboembolic events, suggesting that in terms of study design, some of these trials are designed as classic anticoagulant trials, where other trials are designed as assessing whether treatment dose low molecular heparin can actually be a therapeutic strategy in COVID-19 disease. This represents the design of our own HEP-COVID trial, which is a multi-center trial conducted in the United States. This is randomized, pseudo-blinded, and an active controlled trial. We see here the trial design. We're including very high-risk patients who have D-dimers greater than 4 times the upper limit of normal. Patients are randomized into 2 strata, whether they have ICU level care or care in the medical ward, and they're randomized to receive an enoxaparin at a dose of 1 milligram per kilogram sub-Q BID, or standard of doses heparin. All patients will get day 10 plus 4 screening Doppler compression ultrasonography with a 30-day follow-up. The primary efficacy endpoint is a composite of total VTE, ATE, and all-cause mortality on day 30. Other key secondary efficacy endpoints include progression to ARDS, new onset atrial fibrillation, need for intubation, acute kidney injury, non-fatal cardiac arrest, and rehospitalization at day 30. And the principal safety endpoint is major bleeding using ISTH criteria. Now, the bottom right describes our study hypothesis. And again, what I'm pleased to say to this group for the first time is, as of last week, we have closed our trial and have met our target population of 246 evaluable subjects. Also, suffice to say at this point that the pooled analysis suggests a primary efficacy rate of 30%, which is an extremely high pooled rate, suggesting that we have indeed enrolled a very high-risk population. And these rates represent thrombotic rates that we've not seen as clinical thrombologists in 40 to 50 years in hospitalized patient populations. Now, there's some early clinical trial results that I will briefly describe. This result, small trial, 20 patients coming out of Brazil, suggesting possible advantages of therapeutic over prophylactic anticoagulation in terms of a decrease in ventilator-free days and improved oxygenation. However, the Inspiration randomized trial that was published fairly recently suggested no benefit of intermediate over standard dose heparin in ICU COVID patients in the composite primary outcome of arterial or venous thromboembolic disease, all-cause mortality, or treatment with extracorporeal membrane oxygenation. Furthermore, we've had some conflicting results from the large multi-platform trials, as I mentioned. In December 22nd, the trial paused enrollment in the ICU populations due to safety concerns and potential lack of efficacy of therapeutic anticoagulation, whereas a month later, the same clinical trial group paused trials because of the opposite effect, the suggestion that there was improved efficacy and need for organ support and possibly a mortality advantage in the medical ward patient populations. The published results of these trials are actively anticipated, and suffice to say that what the totality of data suggests is the potential for the mechanisms of reduction of COVID-19 coagulopathy using heparins, and specifically low liquid heparins, are not due to the prevention of the incidence of thromboembolic disease, but the potential off-target effects of these agents, with potential anti-inflammatory effects suppressing the development of cytokine storm, and potential for antiviral effects by competitively binding to coronavirus rather than the native heparin sulfate, suggesting that, again, there may be an advantage of these agents using their pleiotropic effects if used early on in the disease process. But of course, the full totality of data is forthcoming and hopefully will shed some light in the next few months. Some other aspects that I think are worth mentioning with respect to this disease is, as of last month, we have undergone 2 very large external validation studies validating the, again, already validated improved DB tool for VTE risk in hospitalized COVID-19 patients. And on the right, we see a very reasonable ability of the score to discriminate venous thromboembolic disease with an ROC of approximately 0.70. And also importantly, for the first time, this validation ever suggests that whereas up to 50% of COVID-19 patients are at high risk for VTE with symptomatic event rates of greater than 5%, up to 20% or 1 in 5 patients may be at low risk for VTE and may be subject to harms if a universal thromboprophylactic strategy is being used. The other, I think, important work that we published a few months ago is in the rates of post-discharge thrombosis and mortality in hospitalized COVID-19 patients. Previously, retrospective reports suggested a low risk of these events, but subsequently, the ongoing prospective registry, CORE-19, that we recently published, involving more than 4,900 patients, in which post-discharge prophylaxis was given to patients at a perceived high risk of thrombosis, showed a much higher all-cause mortality rate in 90 days post-hospital discharge of about 4.8%, overall thromboembolic rates of 3.2%, major bleeding rate of 1.7%, and rehospitalization rate of 15%, which is quite high. Some of the key predictors after multivariate analysis of post-discharge thrombosis and death included what we may predict of advanced age, the presence of cardiovascular risk factors, the presence of chronic kidney disease, an ICU stay, but also an elevated improved score of 4 or more. And lastly, and importantly, in a multivariate analysis, the receipt of post-discharge extended thromboprophylaxis decreased thrombosis and all-cause mortality significantly by 46%. And this represents our extended VT prophylaxis algorithm that we adopted very early in the pandemic back in April at our, again, 23 hospital system, so that if patients had advanced age or an elevated improved score, they received post-discharge thromboprophylaxis with a direct oral anticoagulant for up to 30 days. Of course, Professor Schulman, I think, will shed some more light in the role of thromboprophylaxis in non-hospitalized settings, but suffice to say is that there are ongoing very large studies looking at this both in Europe, in the United States, and globally. So, to conceptualize, dear colleagues, we can think of 3 periods of thrombotic risk for COVID-19 patients. The outpatient or pre-hospital period, which we think represents a low-risk period, but which some more recent reports suggest that the risk is higher than anticipated in this population, approaching 1% or more, especially in patients with underlying cardiovascular risk factors. The hospitalization period indeed represents a high-risk thrombotic periods, and the strategy at this point of universal thromboprophylaxis using either standard to potentially intermediate dose heparin, especially low molecular heparin, may be preferred, but of course we need more data to see whether there are clear advantages of using either escalated dose or therapeutic dose heparin in key hospitalized patient subgroups. And lastly, the post-hospital discharge period, we have now data to suggest that this represents an intermediate thrombotic risk period. And if patients have key clinical risk factors such as advanced age, the presence of cardiovascular disease, or an elevated improved score, they may benefit from a strategy of extended thromboprophylaxis, especially with a direct oral anticoagulant for up to 30 days. So to conclude, dear colleagues, some of the key future antithrombotic strategies in COVID-19 coagulopathy involve the complete journey and spectrum of the disease, from the non-sick outpatient to the somewhat sick pre-hospitalized patients with cardiovascular risk factors. And here the key question is there added benefit of using either an agent such as a direct oral anticoagulant with or without background antiplatelet therapy to reduce thromboembolic events and improve mortality? We have now data in the hospitalized population that just shows these patients are at high risk of thrombosis, but further evidence using validated tools such as the improved tool suggests that up to 20% of hospitalized patients may be at low VTE risk and subject to harms with this universal prophylactic strategy. We can appreciate that the critically ill COVID-19 patients represents a unique patient group, and this is where the majority of research is being done in this population using either standard anticoagulant agents such as heparins and low molecular heparins, but other strategies such as receipt of fibrinolytic therapy, the use of danaproid, antithrombin strategies, thrombomodulin, or activated protein C, and others. And lastly, in the post-hospital discharge period, again, we're coming closer to an understanding of which of these patients are at high risk of thrombosis and death in the post-hospital discharge period, and whether receipt of such agents as direct oral anticoagulants, again, with or without background antiplatelet therapy, may confer advantages. Thank you very much for your attention.
Thank you, Alex, for your fantastic presentation, very useful for practical doctors. Thank you very much. I think you will get a lot of questions. Our next speaker, dear colleagues, Professor Sam Schulman. Professor, you can start your presentation in 30 seconds after video profiles.
And these are my disclosures. Not really relevant for this presentation. The objectives for prophylaxis are several. First of all, we might want to prevent hospitalization or death. We might want to prevent need for supplemental oxygen, and we might want to prevent blood clots in the legs or the lungs. So how could the prophylaxis help the patient? Mainly in two ways. One, by reducing the inflammatory response, and that could be in several different ways. For instance, by increased blood flow or preventing permeability through the blood vessels, extravasation of leukocytes, reducing fever, etc. The second important way is, of course, to reduce the hypercoagulability. I'll give you now a brief review of some pharmacological tools that have been potential candidates, and hydroxychloroquine was very popular at the beginning of the pandemic, and there were preliminary presentations from studies that it had a positive effect. It's of course a drug that has been used for many years, is available in almost every country, and is not expensive. It has immunomodulatory, anti-inflammatory, and antithrombotic effects, and it is used often in patients with systemic lupus, also sometimes in patients with antiphospholipid syndrome, and in other systemic inflammatory diseases. A systematic review of 12 trials in the Cochrane database found that when patients are asymptomatic but test positive for COVID-19, then it's uncertain whether hydroxychloroquine or chloroquine provide any benefits at all. And there is no evidence that it reduces hospitalization, but it does increase the risk of adverse events compared to placebo. Next, for SARS-CoV-2 monoclonal antibodies against the virus have been tested in different situations, and the main ones are bamlanivimab and casavirimab. And bamlanivimab was tested in a phase 2 trial in outpatients, and it did reduce the viral load, but it wasn't dose dependent. So you can see that most reduction was in the middle dose, which is not what one would expect. The National Institutes of Health in the United States says in their guidelines that it's uncertain whether these agents have any effect in non-hospitalized patients. Next, we'll talk a little bit about convalescent plasma. So that is plasma from patients who just had the infection and survived and are testing PCR negative but have high titers of the SARS-CoV-2 antibodies. And that has been evaluated in several studies, different stages of COVID-19. So in a study in outpatients who they were elderly and they had symptoms, so the convalescent plasma reduced deterioration. This was a small randomized trial in 160 patients, so you can see the Kaplan-Meier plot here on the bottom of patients who remain free of severe respiratory disease, and there were fewer with a p-value of 0.03 among those who were randomized to convalescent plasma. Unfortunately, then a meta-analysis of 4 randomized trials did not show any benefit at all. So we are not sure for which patients and how to use it to derive optimal benefit. Another substance of interest could be interferon beta 1a, which can be given in nebulized form and has been tested in a double-blind randomized controlled trial. However, this was in hospitalized patients, 98 hospitalized patients who inhaled the interferon daily for 14 days, and there was about twice as much improvement according to the odds ratio with those who got the active substance interferon, and no deaths versus 3 in the placebo group. So this is something of interest and should be evaluated further in non-hospitalized patients because it is fairly simple to administer. Another drug that is widely available, and I'm talking about in comparison to hydroxychloroquine, is fluvoxamine, which has been used for many years for compulsive obsessive disorders. And it exerts a sigma-1 receptor agonism with reduction of sepsis-related inflammatory response. So the dose is 100 milligram 3 times a day during 15 days and was tested in a randomized controlled trial in 152 outpatients. So they were infected with COVID-19 but were not as ill as requiring hospitalization, and the fluvoxamine was associated with reduced clinical deterioration, actually 0 versus 8.3%, and quite significant difference. And then another study by Seftel showed that in a non-randomized prospective cohort where patients were offered the treatment, 48 refused, but they were also followed, and 65 were treated, and among the 65 treated, none needed hospitalization versus 12.5% among those who had refused it. And also nice p-value there for significance. So this needs to be evaluated further. Now I'll talk a little bit more about sulodexide. So that is a heparin-related agent. It contains 80% heparin sulfate and 20% dermatan sulfate. So it is an antithrombotic agent and has mainly been studied as such. It also lowers fibrinogen and PI1, has an antithrombin effect. It reduces smooth muscle cell proliferation. It can be given by mouth and has a median bioavailability of 40%, not so bad. And it is safe in renal insufficiency. A meta-analysis published by Bigdale in Seminars of Thrombosis Hemostasis last year of 6 randomized controlled trials in different populations, but with the main purpose to reduce thromboembolic events, showed that versus placebo, there was reduced mortality, reduced myocardial infarction, and reduced deep vein thrombosis without any increase in bleeding. So a group of colleagues in northwestern Mexico decided to try sulodexide early on in this pandemic. And this was at a time point where really nobody knew what would be best, and there was no standard to give low molecular weight heparin. And they chose out patients who had symptoms and suspected COVID-19. So immediately when they had suspected COVID-19, they took the test, but they didn't wait for the PCR test, and they randomized the patients, and 157 in each group to take sulodexide orally twice daily. And then afterwards, they excluded those who turned out to be PCR negative. Some were lost to follow-up, and some refused follow-up. So there were 124 and 119 in each group. And this has now been published in Thrombosis and Hemostasis. So these patients, as I said, they were a bit older. They were over 40 years of age, and they had risk factors. So they had some additional disease, but they also had symptoms. So they had to have 2 of cough, fever, or headache, and 1 of runny nose, dyspnea, diarrhea, loss of smell or taste, conjunctivitis, or body muscle ache. And as I mentioned, the dose already, and that was given for 1 week at a time and delivered to the patient. Either a family member picked it up or some staff delivered it to them. And then every week they also had some follow-up, and blood tests were done on initially and on day 14, and the main outcome assessment was on day 21, and the primary outcome was need for hospitalization. And according to the intention to treat, 15% with sulodexide and 24% with placebo. And per protocol, so those who follow the protocol, 18 versus 29%, and that was statistically significant. And you see the Kaplan-Meier plot there. There were also some significant improvements in secondary outcomes. For instance, there was, with sulodexide, decreased need for supplemental oxygen, 30% versus 42%, and the number of days on oxygen support were 9 versus 11.5, also significantly reduced. The deaths were not significantly reduced, but there were 2 versus 6%, so numerically reduced. And invasive mechanical ventilation, numerically reduced, but not statistically significant. No difference in thromboembolism or major bleeding. And it was interesting that they took lab tests initially and after 14 days, and they were focusing on D-dimer and C-reactive protein, and could show that on day 14 there was an increase in both groups of D-dimer and C-reactive protein, a little bit, but much less of an increase in the sulodexide group than in the placebo group of both D-dimer and C-reactive protein, which indicates that sulodexide could have exerted some anti-inflammatory effects. Now, I said that the thromboembolic events were not reduced. A study that was published in JAMA, Internal Medicine, looked at 30 days rate of venous thromboembolism in a large healthcare system in California called Kaiser Permanente. And they looked retrospectively at over 200,000 patients with PCR testing, and 26,000 tested positive. And among those, within 30 days, 198 of the positive and 1,000 of the negative had venous thromboembolism. But when they looked at whether they were outpatients, hospitalized, or after discharge, so they saw that the only subset that there was a difference in rate of venous thromboembolism between those testing positive and testing negative was among those hospitalized. Whereas in the patients who were just treated as outpatients, there was no difference, and the rates were low. So one could speculate that it is not worth aiming for a reduction of venous thromboembolism in outpatients, but more to aim at reducing hospitalization and oxygen support. So in conclusion, ladies and gentlemen, pharmacological prophylaxis in non-hospitalized patients with COVID-19 in order to reduce thromboembolism is probably futile because of the low baseline risk. But we should aim for reducing the risk of clinical deterioration. And some agents show preliminary promising data. Those are nebulized interferon beta-1a, fluvoxamine, and sulodexide. But further studies are obviously needed to confirm these rather preliminary findings. And with this, I would like to thank you for your attention. This is the view I have in a few days from now when the trees below my window will blossom. Thank you.
Thank you very much, Professor Schulman. We have to continue our conference. Our next speaker is Professor Jean-Christophe Gris. Professor, can start your presentation after 30-second profile, video profile.
Thank you very much, Mr. Chairman. Well, I would like first to warmly thank the organizers for giving me the opportunity to participate in this nice scientific and medical event. We shall today review together the association between SARS-CoV-2 infection and thrombogenic autoantibodies. First, my disclosures. To begin, what were the main points we had progressively learned on antiphospholipid antibodies before the COVID era? To recall the story, antiphospholipid antibodies, I shall say, APLA, were detected as inducing biological false positive tests for syphilis, these tests containing phospholipids. One of these phospholipids, cadolipin, were then purified and used. APLAs were subsequently consistently described in patients with emblematic systemic autoimmune diseases. It is really crucial to understand that an artifact, the phospholipid dependence of these antibodies, led to identify the first thrombogenic autoantibodies. APLAs are now described as autoantibodies against phospholipid-affine glycoproteins, the so-called cofactors, which leader is beta-2 glycoprotein 1, I shall say beta-2 GP1, prothrombin being the second one. The three laboratory markers have been progressively recognized with very heterogeneous clinical values. The first one is the so-called lupus anticoagulant, LA, detected through coagulation tests. Then solid phase immunological assays can detect anti-lipid antibodies, and more recently, anti-beta-2-GP1 antibodies, which seems to be the marker of worse prognosis. The fourth one, anti-prothrombin phosphatidylserine antibodies, is progressively emerging. The antiphospholipid syndrome APS classically associates objectively proven clinical complications, which can be related to thrombosis of pregnancy, morbidities, and at least one persistently positive APLA. We now really understand the pathophysiology of APS as being secondary to an autoantibody-mediated key cells activation syndrome, among which are platelets, monocytes, endothelial cells, and trophoblasts, cell surface receptors to cofactors, inducing signalization pathways prone to modulate critical cell functions. Very recently, this fantastic work could also identify the endothelial protein C receptor combined with lyso-biphosphatidic acid as an APLA target, thus allowing the autoantibody internalization, which consequences seems to explain the strong link between coagulation and autoimmunity in APS. APS obeys to the two-hit theory. The first hit is related with the interaction between autoantibodies and key cells. The second hit to an intercurrent event generating inflammatory conditions prone to upregulate cell surface receptors. And transient positivities for APLAs have been extensively described in a number of infectious diseases, among which are a lot of viruses, and in this case, clinical symptoms remain rare, but are not zero. So, taking that in mind, what is the epidemiology of APLAs in SARS-CoV-2 infection? A first limited report in a prestigious journal described 3 very severely compromised patients with multiple arterial thrombosis. The striking fact was positive anti-cardiolepin and anti-beta-2-GP1 IgA, and no LA detection despite positive anti-beta-2-GP1 IgG. The accumulation of data convinced the Cornell University team in New York City to perform a review on 23 very heterogeneous studies. LA was found positive in 2/3 of tested patients, anti-beta-2 antibodies in 1/8, and anti-cardiolepin antibodies in 1/10. A correct use and measurement of APLAs was strongly encouraged. This Mexican case series study found as high as 77% of both criteria and non-criteria APLAs in patients with severe and critical COVID-19. A subsequent short report from London focused on patients with severe COVID-19 with a prolonged APTT value and claimed 9/10 of them having a lupus anticoagulant. The high incidence of LA-like activities in patients was confirmed in that study from Mulhouse, the epicenter of the first infectious wave in France. And also in the study from the Shared Zedek Medical Center in Jerusalem. A new review performed in the early beginning of this year describes half of the patients with COVID-19 being positive for APLAs, mainly due to LA positivity, anti-beta-2-GP1 antibodies being more rarely positive. Few studies really describe the kinetics of APLAs in patients. This Chinese one, performed in 66 patients, half of them being positive, finds all cases: persisting IgG autoantibodies after transient IgA, persisting IgA after transient IgG autoantibodies, high levels of IgA autoantibodies, but also transiently positive autoantibodies not followed by any persisting positivity, the incidence of this kind of reactivity being currently not documented. Does COVID-19 severity modulates APLAs? This multicentric Italian study from Padua describes a subgroup of non-hospitalized COVID-19 patients with a 50% positivity rate of aplas, mainly isolated LAs, and no symptomatic thrombotic event. This French study from the Salpêtrière group focused on hospitalized patients with a moderate disease not necessitating oxygen therapy, also finds a positive rate close to 50%, also mainly LA activities, double or triple positivity being rare, thrombotic events striking 1/10 of the patients. In hospitalized patients with a moderate disease and a non-invasive oxygen therapy, the Padua group describes a positive rate close to 40%, mainly positive anti-cadilipin antibodies, and thrombotic events in 40% of the patients. In patients with a severe disease and a non-invasive oxygen therapy, the study in Switzerland mainly finds a marked elevation of total IgA, the severity being correlated with aplas of IgS isotype. The study in Ghent, Belgium, on patients with a severe disease necessitating invasive oxygen therapy finds at least one positivity in 3/4 of the cases, mostly transient anti-aplas, a positive LA activity in 2/3 of the patients, with thrombotic events in 30% without any clear associations with aplas. Finally, the study of critically ill patients necessitating extracorporeal membrane oxygenation found 90% being positive for LA activity, with a double positivity in 50% and a significant rate of pulmonary embolisms. And this other Chinese paper on critically ill patients with a refractory disease found a positive rate of 50%, mainly IgA autoantibodies, with a double positivity in 1/4, antibodies emerging 1 month after disease onset, with mainly transient antibody kinetics. So the question is, can we trust these technical results? A letter published more than 10 years ago demonstrates that T-reactive protein interferes with LA test results in inflammatory conditions, thus altering the specificity of dedicated coagulation tests for LA diagnosis. The recall of this strong limitation led to recent specific warning on false positive results in patients with COVID-19. And this very nice study from the Milanese group also found no association of aplas with thrombosis, positive aplas being mainly directed against beta-2-GP1, but displaying epitope specificity very different from the one described in the thrombotic antiphospholipid syndrome. This group clearly suspecting non-clinically relevant aplas. So, are aplas a clinical concern in patients with COVID-19? A retrospective study in Montefiore Hospital, New York City, compared the positivity rates between COVID-19 and non-COVID-19 patients and found a positive LA activity associated with thrombosis after adjustment on CRP levels. However, the study from Catherine de Vries in Ghent found no clear relation with thrombosis. And this strong doubt is relayed by the Larry Brazier team in Paris, showing no association of LA activity with thrombosis in critically ill COVID-19 patients. A prospective Spanish case control study shows higher rates of positive anti-beta-2 IgA in patients, but no significant difference on survival, thrombosis, and ventilation failure. They also describe lower circulating concentration of beta-2-GP1 in COVID-19 patients, low levels being associated with ventilatory failure, but we do not know if it is a pure consequence of a real risk factor. What about experimental data? A series of works has been published by Jason Knight's labs in University of Michigan. The first one shows that purified IgG from patients with COVID-19 can promote net release from healthy human neutrophils and can accelerate venous thrombosis in 2 mouse models. However, even if purified IgG can be positive for aplas, no further purification of aplas from purified IgG was performed, and we thus cannot extrapolate that the thrombogenic IgG are really aplas. A second work shows that purified IgG trigger a pro-adhesive phenotype for leukocytes in cultured human endothelial cells. But here also, the absence of specific purification of aplas from purified IgG cannot allow any extrapolation. And the last work showed that circulating immunoglobulins have an anti-net activity, likely to impair net clearance and to potentiate thromboinflammation. But again, we cannot extrapolate on the apla nature of these O2 antibodies. Complement activation is increasingly underlined in APS. Interestingly, SARS-CoV-2 spike protein can directly activate the alternative complement pathways. This might potentiate the pathogenicity of aplas. More generally, SARS-CoV-2 is an experimental trigger of autoimmunity. COVID-19 and autoimmune disease share clinical similar features. First, on overactivation of innate immune cells. Second, on altered circulating counts and dysregulations of adaptive immune cells. Third, on increased circulating levels of cytokines and chemokines. We've seen that before. Fourth, on increased rates of a number of autoantibodies. Fifth, on clinical conditions. And last but not least, on increased levels of damage-associated molecular patterns and on molecular mimicry. A number of human proteins share heptapeptides with SARS-CoV-2 virus. A number of autoantibodies are described during SARS-CoV-2 infection, and a number of autoimmune diseases are described during SARS-CoV-2 infection. To summarize, SARS-CoV-2 infection associates molecular mimicry to an hyperstimulation of the immune system, which creates the optimal conditions for the onset of autoimmune diseases. And this case control study in Bogota, Colombia, shows an increased rate of a series of autoantibodies in hospitalized COVID-19 patients. So to conclude, SARS-CoV-2 infection really generates de novo aplas, which can be transient or persistent, with a high rate of positive HLA activity and a very original rate of positive autoantibodies of IgA isotype. However, we have seen that the consistent part of these autoantibodies is probably not clinically relevant, with false positive LAs and the questionable anti-beta-2 IgG. The incidence of aplas is not obviously associated with COVID-19 severity. Their thrombogenicity is suspected, but not definitely demonstrated. Patients do have experimentally thrombogenic circulating antibodies, which are not demonstrated to be aplas. All that in a complex context in which the virus generates autoimmunity. However, this clinical situation is the first large-scale morbid condition, which would demonstrate, if any, the clinical relevance and thrombogenicity of transient aplas and of aplas of IgA isotype. To finish, I would like to thank my colleagues and coworkers in Nîmes and Montpellier, my so brilliant colleagues today coming from all over the world, and of course, the medical dream team of gynecology and obstetrics in the Tischendorf University. Thank you very much for your attention.
Thank you very much, Jean-Christophe, for your really very nice presentation. Dear colleagues, our next speaker, it's a Russian team.
Уважаемые коллеги, добрый
Dear
день.
colleagues, hello. It's a great honor for me to speak at such an honorable scientific event. The topic of my presentation is COVID-19 and hemostasis disorders. New virus, SARS-2, COVID-19, have turned the world upside down. It's an alliance of cytokine storm and different disorders. And the connection between this, all these conditions, including this septic shock and devious, have a great impact on the humanity. And some markers are already showing a very bad prognosis for COVID-19 patients. And several months after the pandemic started, we saw that apart from the multi-organ disorders and hypercoagulation, and hemostatic disorders play the leading role in this, lead to very grave conditions. And in most patients, in 100% of cases, we see the hemostatic disorders. And for severe patients with COVID-19, with the great conditions, we see significant changes. The fibrillous thrombotic angiopathy and venous and arterial thrombosis and catastrophic antiphospholipid syndromes. And we saw that this disease sometimes manufactures as classic lung thrombosis with lead to lung damage and which reminds this catastrophic antiphospholipid syndrome due to this systemic thrombosis, which now is called a thrombotic storm, like cytokine storm. The autopsy results revealed in Hamburg that the frequency of the venous thromboembolism among the COVID-19 patients is very high, and it is not only the factor for hospitalization, but it also determines the gravity, severity of the disease, and the lung disorders leads also accompanied by embolism, and sometimes it's a local thrombosis. And recent Italian studies show that in spite of the standard anticoagulation therapy, 27% of patients had this lung thromboembolism, and it was developing without the deep vein thrombosis, and which is quite unusual. The COVID-19 indirectly or induced lung disorder is a local lung pulmonary induced syndrome, and it differs from the IRDS of other etiology, and we see that the lungs are affected, and the lung coagulopathy is developing. One of the features of the ARDS in COVID-19 patients is the presence of the virus inside cells, and the microvascular disorders demonstrated on the pictures show us this. They lose the hierarchy of vessels, and we also identify the other disorders, and resistance to fibrinolysis is a potential mechanism for patients of COVID-19. Apart from this very grave thrombosis, and we see the development of acute respiratory distress syndrome and multiple organ failures. And thrombotic microangiopathy describes naturally heterogeneous clinical condition characterized by arterial and capillary thrombosis with the development of hemolytic anemia, cytopenia, and ischemic organ damage, including multiple organ failure. We also see some atypic manifestations like malignant hypertension, and we also see several factors, and some of them are associated with this deficit of metalloproteinases. The defects of Adams 13 enzymes are associated with inadequate thrombolysis of Willebrand factor multimers, having a strong capacity to activate thrombocytes. And it's known that systematic inflammation and cytokine storm is the main reason for endothelium damage, and due to intracellular gaps or nets, which are like nets of chromatin threads, which of granular origin, and nets are capable of activating endothelium, which lead to Willebrand factor multimers, and it leads to the consumption of Adam 13, and the more is the deficit of these enzymes, the heavy is the clinical picture for such patients. NETs can also inhibit some natural anticoagulant factors of Adams 13, and as a result of it, the Willebrand molecules will not identify the regular rate of these polymers. And in the third trimester for pregnant women, we see that apart from the physical coagulation in disorders in the pregnant women, we see the risk of grave COVID-19 at the late pregnancy terms. And currently we see few publications on few number of patients with related to Adams 13 factor, and the results are just brought down in the table on the slide, and you see the general tendency is the reduction of Adams 13 level and the reduction of Willebrand factor rates, which go down as because of the heavy inflammation and endothelium damage and high molecular factor Willebrand's demise. And it is actually a substrate for Adams 13, and with this high level of Willebrand factor, we observe the grave forms of COVID-19 conditions. This is the findings of our research sponsored by the Russian Academy of Science. We took 313 samples of the plasma and studied NETs and Adams 13 levels and see the connection between the severity of the disease, and we evaluated cytokine antibodies, and we also defined antigenes activity inhibitors of Adams 13 and Willebrand factors, and increased activity of oxidase was high among those patients who died compared to those who survived. Adams 13 activity was also lower in these patients, and high factor the Adams 13 inhibitor level was higher statistically, and and it is an evidence of a very severe and bad outcome of COVID-19. We believe that the reduction in activity of ADAMS13 is not the consumptions of the antigen by this Willebrand factor at the backdrop of the endothelium damage, but due to some other mechanisms, say excessive NETs occurrence or some other systematic inflammatory response. Other symptomatic manifestation may be connected to autoimmune process and for this or inhibitors of ADAMS13. As for the pregnant women with COVID-19, we examined 68 samples of their plasma, and with 30 of the patients, 30 of samples were COVID negative, and we see that high level of Willebrand factor, which is typical for physiological pregnancy, but at the same time, those COVID-19 positive patients have a higher level of Willebrand factor. And at the same time, the reduction of ADAMS13 reduction was statistically insignificant. Out in 11 patients, it is patients, we saw typical placenta-associated complications. In 3 women, we saw hypoxia of fetus and the growth retardment. We saw no female mortality, but we believe that we didn't observe any clinically diagnosed thrombosis, but in international literature says that the thrombosis in placenta is common, but we haven't seen it in our research. And at this slide, we show you one of the largest systematic reviewed meta-analysis of women with COVID-19. Out of more than 1,000 women with COVID-19, we saw 3 arterial or venous thrombosis, 6 cases of DIC syndrome, and 17 maternal deaths. And this meta-analysis also showed that the risk of thromboembolical complication is 3 times higher in COVID-19 positive women, and hemostatic disorders are 10 times higher in COVID positive patients compared to non-COVID or COVID negative women. And another research, UK obstetric surveillance system, which we included in our review. And the first data covered the 427 pregnant women. My conclusions were that pregnant women have no higher risk of acquiring, of contracting COVID-19. 2/3 of women have asymptomatic COVID-19, and IT hospitalization is higher in pregnant women, in women older than 35 years. And we have the similar findings in our setting. Most of women were actually discharged after follow-up, after we had only have 8 deaths, but these women were pregnant and they were of some African origin, and high risk was associated with age above 35 years and with other health problems before contracting COVID-19. And the last study, which is we address, is the Queen's College of OBGYN. RCOG, and there we see similar conclusions, but compared to non-pregnant women, the pregnant women with systemic COVID-19 which need hospitalization have worse outcomes and higher maternal death risk, although it is very small one. As for target therapy for in COVID-19 pregnant women, we believe that thrombosis plays a very important role for these patients, and thrombogenesis in these patients should be suppressed at different pathogenetic levels, and this not only anticoagulants should be used, it's not sufficient. High D-dimer level patients should be hospitalized even if no other manifestations are present, because this is a very bad prognostic marker. And D-dimer is a question. Can it be a biomarker of the worsening of the conditions of pregnant women? And sometimes now we don't have any guidelines in this field for such patients. As for the other strategy, these patients need anticoagulants, and low level heparins should be the first line treatment. Oral medicine should not be administered to these patients, and as for non-coagulant effects of heparins, it's connected with this lung fibrosis, and in order to stimulate endothelial growth factor, we need heparins with this chain of more than 22 saccharides, and because otherwise it leads to the some more adverse outcomes. As for antivirus effects, these 3D analysis for SARS-CoV-2 has a structural similarity with active FXA and thrombin factors, and can directly affect the blood coagulation. And experiments show that the direct inhibitors of FXA can inhibit invasion of SARS-CoV-2. As for pregnant women, we were contracting COVID-19, they have a higher DVE factor and risk, and bleeding is a very rare event in pregnant women with COVID-19. Thrombosis can occur in spite of prophylactic and therapeutic use of heparin, and ARDS and heart failure can be probably informed by microthrombs than by isolated immune activation. Therefore, my conclusion is that anticoagulant and multiple anticoagulant effects of low molecular heparin, we need to administer it at early stages for protective and reparative effects for endothelium and other cells, and because the disease can develop like a tidal wave.
Thank you very much, our Russian colleagues, for your presentation. Very informative. Dear colleagues, our next speaker is Professor Jihan Hai. Professor, please remember that we need 30 seconds to organize your profile.
Dear ladies and gentlemen, dear colleagues, it's my great pleasure to give this lecture today on COVID-19 and thrombosis, and specifically talk about a new form of coagulopathy and risk of thrombosis after vaccination against COVID-19, which is currently a hot topic in some parts of the world, including Europe and North America. My name is Jihan Hai. I'm an associate professor at the Medical University of Vienna in Austria. I'm trained in internal medicine and hematology. My clinical and research work focuses on thrombosis and hemostasis and anticoagulant therapy. I'm also honored to be a guest professor at the Sechenov First Moscow State Medical University in Russia. This is the outline of my presentation. I will start off by briefly giving an overview on the risk of venous thromboembolism in patients with COVID-19, and then highlight a new form of coagulopathy, a new syndrome that was described after COVID-19 vaccination. And finally, I will discuss a recent publication which has reported the risk of venous thromboembolism following COVID-19 vaccination. And the question here is that we want to address is the risk of the classical form of venous thromboembolism, that is deep vein thrombosis and pulmonary embolism, increased after COVID-19 vaccination. Let's start with the risk of venous thromboembolism in COVID-19. COVID-19, primarily a respiratory disease, has many systemic complications. Early studies have reported high rates of venous thromboembolism in patients with COVID-19. However, these studies were highly heterogeneous, and the VTE rates ranged from 0 to 85%. We wanted to understand the risk of venous thromboembolism in patients with COVID-19 better, and therefore we performed together with my co-workers, Dr. Knopp and Dr. Moig, a systematic review and meta-analysis to provide a good estimate for the risk of thrombosis in COVID-19. We screened all literature published until September 2020, identified 66 studies for the meta-analysis and for the quantitative analysis. Overall, most of the studies came from Europe, followed by North America, and there were some studies where patients who were hospitalized for COVID-19 were systematically screened for venous thromboembolism. And if we look at the patient characteristics, so we see a mean age of 63 years. So that is representative of people with COVID-19 who were hospitalized during the first wave of the pandemic. Most of the patients were male. The overall estimate in the meta-analysis was 14% VTE risk in patients hospitalized for COVID-19, which is a quite high risk for VTE. And if we look at the different groups of patients, so we see that the prevalence of VTE was higher in patients that were hospitalized and required ICU treatment. So in ICU COVID-19 patients, the prevalence was 23%. and most of the patients had pulmonary embolism. So 13.7% had pulmonary embolism. In non-ICU hospitalized patients, so patients that were on the wards, the overall VTE prevalence was 7.9%. And again, most of the events here were pulmonary embolism that were reported. Interestingly, so with the pandemic, so the risk of thrombosis in studies decreased over time. So this is a very interesting trend showing a decreased thrombosis rate over time that might reflect a better management of COVID-19 patients hospitalized, and maybe better implementation of prophylactic strategies. Now I would like to continue with a very hot topic. Only recently a new form of coagulopathy after COVID-19 was reported, which is termed thrombosis with thrombocytopenia syndrome, also sometimes termed as vaccine-induced thrombotic thrombocytopenia. In March 2021, several cases of a severe thrombosis, mainly at unusual sites like in the brain with thrombocytopenia occurring post-vaccination, were reported in some European countries and in the United Kingdom in individuals receiving the AstraZeneca vaccine against COVID-19. And this was also later reported in the United States after vaccination with the Johnson & Johnson vaccine. And this form of coagulopathy has a very distinct clinical and laboratory characteristic, which I will detail a little bit later. And there were also different names, other names for this coagulopathy. For instance, first it was named vaccine-induced prothrombotic immune thrombocytopenia, then changed from VIPID to VIT, but now by some organizations and institutions, it's frequently termed thrombosis with thrombocytopenia syndrome, a term probably which reflects the whole spectrum, the new coagulopathy best. And here is a summary of the clinical and laboratory characteristics of patients reported in the first publications from Austria and Germany, Norway and United Kingdoms. So this form of coagulopathy occurred 5 to 24 days after vaccination with the AstraZeneca vaccine. And most of the affected people were female, and the median age here, or the age range was 22 to 49 years in the Austrian German reports, 32 to 54 in the Norwegian study, and 21 to 77 years in the study from the UK. And the lowest platelet count was here around 10, and overall, all patients had a thrombocytopenia with a different degree. And interestingly, patients had positive antiplatelet 4 antibodies. So the ELISA for the antiplatelet 4 antibodies was positive in almost all patients here, and it was also confirmed that these antibodies here were platelet activating. And this is a very interesting phenomenon, and it's a, like, let's say it's a hit-like phenomenon, a phenomenon that we call heparin-induced thrombocytopenia. These are the antibodies that we usually determine in this case. However, in this case, these antibodies were positive without exposition, without use of heparin. So this Probably this is due to an immunological trigger after vaccination, where antibodies against platelet factor 4 are produced. And the thrombotic events that occur are mainly at unusual sites, cerebral venous thrombosis, but also thrombosis in other very unusual sites, for instance, in the abdomen, in the splanchnicus vessels, but also classical thrombosis like pulmonary embolism and deep vein thrombosis can occur. And in the UK study, also 4 arterial events were reported, and this was in these studies, this was reported after vaccination with the AstraZeneca vaccine. And interestingly, I would like also to add that D-dimer was highly elevated in all patients, fibrinogen was low in the majority of patients, and these complications had a life-threatening, caused a life-threatening situation, and the mortality rate was very, very high, reported especially in the Norwegian study and also in the study from Austria, Germany. Some of the cases died here. And the question now is, how can we diagnose or identify patients at risk for VID, and how can we diagnose such patients with this new form of coagulopathy? International societies have promptly reacted to this issue and have established and published guidance statements and recommendations. And first of all, you have to consider that that such symptoms occur about 4 to 28 days, or such complication occurs after 4 to 28 days after vaccination with the AstraZeneca or the Johnson & Johnson vaccine. It has not been identified after other vaccines currently, and you have to look for signs and symptoms that are suggestive of thromboembolism. For instance, severe persistent headache, vision change, neurological changes, which can be an indication for a thrombotic event in the cerebral venous system, or severe persistent abdominal pain, leg swelling, or pain as symptoms for deep vein thrombosis, or chest pain and shortness of breath as symptoms for pulmonary embolism. However, this is not limited just to thrombotic complications such as coagulopathy, and sometimes also initially other symptoms can occur, which usually occur when patients have low platelets counts, have a thrombocytopenia, and you should also consider symptoms like petechia and new bruising, as I will show you in a case later here. And then how should we diagnose VID here? First of all, if you have such a patient, so you order a complete blood count analysis. You look at the platelet count and see if there is thrombocytopenia, low platelet count. You should also order other standard coagulation laboratory tests like the prothrombin time, the APTT, fibrinogen, and also D-dimer, because D-dimer is usually very high, fibrinogen sometimes low. And then, of course, if you have a suspicion of a thrombotic event, you should order an appropriate imaging test to confirm thromboembolism based on symptom presentation, for instance, CT or MRT for headache, or CT for abdominal pain, or CT for chest pain, or an ultrasound sound investigation for leg swelling or leg pain. And the next question is how we diagnose then really VID and this new form of coagulopathy. So you should, first of all, the specific testing begins with binding assay and ELISA to identify the presence of antibodies against platelet factor 4. So usually we use this tests when we have a suspicion of heparin-induced thrombocytopenia, but it detects antibodies against antiplatelet factor 4 complex with heparin or other or with polyanions. And then you need a specific test, a functional hit assay, if this is available. There are different functional hit assays. For instance, the heparin-induced thrombocytopenia platelet activation assay, or a platelet or the serotonin release assay. And a positive result in this hit functional assay strongly suggests that this person has a VIT in the appropriate clinical setting. What is the treatment of VIT? So based on expert recommendation guidance, so the recommended treatment is to give high dose of intravenous immunoglobulins in a dose of 0.5 to 1 gram per kilogram daily for 2 days. Start with steroids if platelets are low. Avoid platelet transfusion, heparin, low molecular weight heparin, and use a non-heparin anticoagulant, for instance, fondaparinux, argatroban, or DOAX if a platelet count is above 50, and when there is no serious bleeding. And you can also use danaparoid or orgoran is also possible, especially in patients with a severe thrombocytopenia. You should involve also an expert in coagulation and thrombosis. And in severe thrombocytopenia, after high dose of immunoglobulins and steroids, especially if you don't have a response, so you can also start with plasma exchange. How frequent is this complication after vaccination with the AstraZeneca vaccine or the Johnson & Johnson vaccine? And there are some data reported for the incidence of this complication for the AstraZeneca vaccine. And this is at the end a very, very low incidence of 1 to probably 100,000, 200 patients with vaccination with the AstraZeneca. However, currently, to be honest, the true answer is we don't really know the exact incidence of this frequent coagulopathy after vaccination. However, at the end of the day, it's a very low complication. I would like to present you a very interesting case with such a vaccine-induced prothrombotic immune thrombocytopenia, where we have early recognized the problem, very early started the treatment, and I think we have saved the life of this patient. And this is a 60-year-old lady who presented with bruising, hematoma, which you can see on the left picture, and on the right picture, petechia, this very small, tiny bleeds here in the skin. 9 days after vaccination with the AstraZeneca vaccine. So she contacted us and came to the hospital. So we performed laboratory tests here. So we detected this thrombocytopenia, so 26. D-dimer was very high, 53. Fibrinogen was low, very low. And we performed this platelet factor 4 heparin antibody ELISA, and this was highly positive with an OD of 2.29 here. So then we excluded also thrombosis in this patient here. So this was highly suggestive of such a coagulopathy following the AstraZeneca vaccine, and we started immediately with this high dose of intravenous immunoglobulins. We gave corticosteroid prednisolone. We started a non-heparin anticoagulation with danaparoid danaparoid as an anticoagulant that has a very short half-life. We have chosen this because of the thrombocytopenia, but if you have argatroban, that could be also an option here, but it's important to start with a non-heparin anticoagulant. And then we had also to give fibrinogen because the fibrinogen was very low. And you can see after the first dose of the high-dose immunoglobulins, after starting of prednisolone and the non-heparin anticoagulation. So we see an increase of platelets, an increase of fibrinogen, and a very sharp decrease of D-dimer. So at day 3 of hospitalization. So you see the D-dimer was very low and the lab values, platelets improved, fibrinogen improved, and at day 5 of hospitalization, we switched the danaparoid to oral anticoagulation with apixaban, and at day 19, so everything has recovered and D-dimer was negative again. Interestingly, at day 19, the ELISA for detecting antibodies against platelet factor 4 was still positive, but the OD was low at that time. And finally, I would like to briefly touch upon a very frequent discussion that we have, and that is the risk of venous thromboembolism, of classical venous thromboembolism in the form of deep vein thrombosis and pulmonary embolism following COVID-19 vaccination increased. And here we have a first large analysis, a population-based cohort study from Denmark and Norway, where the rates of arterial events, venous thromboembolism, thrombocytopenia, and bleeding after vaccination with the AstraZeneca vaccine was analyzed. A large study where almost 300,000 participants with at least one COVID-19 vaccination with the AstraZeneca vaccine in these countries were analyzed, and then this was a nationwide study, and this participant, or the rates of these complications in these participants, were compared to rates in the general population in these countries in the years 2016 and 2018 in Denmark, 2018 and 19 in Norway, and the observed rates after 28 days of vaccination were reported here. So this will be the first study that will highlight or show us whether these thrombotic complications are increased after vaccination, in this case with the AstraZeneca vaccine. And this is the result here. So the rates of venous thromboembolism, all kinds of venous thromboembolism, including cerebral venous thrombosis, pulmonary embolism, deep vein thrombosis, was slightly increased. So there were 11 more events per 100,000 persons more than you would expect in this group of patients that received the AstraZeneca vaccine here, including a slight increase of rates of cerebral venous thrombosis. So this is the typical event that was reported in most of the cases with this thrombosis and thrombocytopenia syndrome here. However, there was no increase in arterial events, so this is reassuring. No signal that there were more arterial events following vaccination here. But overall, and this is important to highlight, people who were vaccinated had a lower rate of mortality compared to the reference population here. So you see the overall benefit of vaccination here. The other complications, so thrombocytopenia, occurred slightly more frequent in the vaccinated group compared to the reference population, and also bleeding events occurred slightly higher in the vaccinated population compared to the reference population. However, I think this data needs to be interpreted with caution, because there is reporting bias likely, because there was a huge discussion after vaccination, and probably there was a lot of screening and a lot of assessment here in people who would have not go to the doctor in other situations. So reporting bias could be a problem. So dear ladies and gentlemen, dear colleagues, so in summary, the risk of venous thromboembolism in hospitalized patients with COVID-19 is increased, especially in those at the intensive care unit. And we have seen a new form of coagulopathy syndrome after COVID-19 vaccination with the AstraZeneca and the Johnson & Johnson vaccine. However, the international community has reacted promptly and provided us with guidance and recommendations how to diagnose and how to treat such a complication, which is very, very, very infrequent. And I think my case has shown that an early identification and treatment with non-heparin anticoagulation, with high-dose immunoglobulins and with corticosteroids is a good therapy to prevent here and treat such patients and prevent thrombotic complications. And in a recent population-based study from Denmark and Norway, increased rates of venous thromboembolism were observed within 28 days of vaccination with the AstraZeneca vaccine. There was an excess of deep vein thrombosis and pulmonary embolism, and there was also an excess of cerebral venous thromboembolism in this recent publication in the British Medical Journal. There was a slightly increased rate of thrombocytopenia or coagulation disorders and bleeding in the vaccinated group. However, this all could be influenced by the heightened surveillance, and this could be also subject to reporting bias here. So the absolute risk of all the events were small and should be interpreted in the context of the benefits of COVID-19 vaccination at both the society and the individual levels. Because vaccination, I think, is the only way to get out of this pandemic. With that, I would like to thank you for your attention, and I hope you enjoyed this presentation.
Jihan, thank you very much for your brilliant presentation. Dear colleague, we have final presentation. I would like to invite Professor Benjamin Brenner to do it. And don't forget for 30-second profile, video profile. Please.
Can you see my slides?
No,
Not yet.
Not yet, Benny.
share the screen.
Not yet.
Yeah, I did. It said that that the host stopped it for some reason. Okay. So it's a great pleasure and honor to be a part of this fantastic meeting. I learned a lot, and I would like to thank the organizer for the opportunity to take part. These are my disclosures. So we have already heard that there is a strong interaction between coagulation and inflammation. And this is not only in COVID-19, because there is a strong developmental evidence for coevolution of the inflammatory and coagulation system. And we know for other viruses that endothelial cell injury is quite common and result in overexpression of tissue factors 7A and 10A, thereby increasing the procoagulant effect. But also there is an increase in pro-inflammatory response, and this was dealt with previous presentation, especially by Professor El Alami. So for my presentation, I would like just to say, you see here that COVID-19, it's an immunothrombosis. We heard about the cytokine storm, the macrophage activating syndrome, and we heard from Professor Jean-Christophe Gris about antiphospholipid antibodies. But of course, there is a severe endothelial damage in COVID-19 infection. And we find this also in the histopathology in the lungs with the endothelitis, diffuse alveolar damage, thrombosis and microthrombi, and fibrin plasmin deposition. And when we look at the lab, there is an increase in CRP, IL-6, 8 and 10, TNF, markedly increased D-dimer, and also thrombocytopenia, which is associated with worse prognosis and lymphopenia. And when we look at the comorbidities, of course, the hypertension, cardiovascular disease, diabetes, all these conditions which are associated with endothelial dysfunction. But cancer, you can see that cancer is found in about 2 to 5%. However, when there is cancer, then the cause is much worse. The association of cancer and COVID-19 results in higher morbidity, mortality, and also a higher risk of VTE. Just from a recent publication last month in JPH, 5-fold increase of VTE in cancer patients compared to non-cancer patients from Wuhan. And you can see here that in this relatively large retrospective study of 5,500 COVID-19 patients, including over 400 cancer patients, that there was an 80% increase of VTE. And a meta-analysis of 20 studies showed 70% higher risk of complications in COVID patients with cancer. Now, the risk is especially high in patients with hematological cancer compared to solid tumors. You see that it's 60% higher in general in hematological malignancies, and especially for acute leukemia. You see it's over 2-fold increase compared to solid tumors. And we also have to remember that in patients with cancer, there is also impaired response to vaccination. And I fully agree with Jian that vaccination is the solution as we see in Israel. Now, Jian have so nicely shown these patient-related, tumor-related, treatment-related, as well as biomarkers figure for cancer-associated thrombosis. And for sure, we have to include in this nice figure the COVID-19 infection as a patient-related complication. Now, we have now the opportunity with large data sets to look at cancer and thrombosis in big population like the Danish population, and this is just from a recent study by Mulder, in 500,000 cancer patients compared to 1.5 million individuals from Denmark, and the risk of VT in cancer patients is increasing steadily, and they looked on that over 20 years, starting in 1997. And in general, the risk of VTE is in cancer patients is 9-fold higher as compared to the general population. The hazard ratio are especially high for patients with prior venous thromboembolism, for patients with metastatic cancer, but also are increased for patients on different therapeutic agents such as chemotherapy, protein kinase inhibitor, anti-angiogenic agents, and also for the relatively new agents used in cancer patients, the targeted therapy and immunotherapies. And actually, what is common for many of these medication given to patients with cancer is that they are associated with endothelial dysfunction, as well as an increase of inflammation and inflammatory response. And that's why there is a pathogenetic mechanism for the increased risk of venous thromboembolism in cancer patients, especially in cancer patients who are given therapeutic agents for their malignancy. Now, hematological cancers are a special problem, and this is from a recent paper, again from Denmark, on 32,000 patients with hematological cancer, which were matched with up to, each patient was matched for up to 5 controls. And the 10 years absolute risk for thromboembolism or bleeding complication was actually 1 in 5 patients, almost 20%. And there was an increase in the risk of arterial thrombosis, MI, and stroke, and especially for venous thromboembolism and bleeding compared to the general population. Now, the different hematological malignancies had a different risk. And you can see here the cumulative risk for VTE at 10 years, and you can see here in pink, this is the myeloproliferative disorders. Here in green are the myelomas. And here is the bleeding, the major bleeding that led to hospitalization. And here in yellow, you can see the myelodysplastic syndrome patients. And again, here, the myeloproliferative. So it's a very high risk, up to 15% at 10 years. And the risk is very high also in the beginning. And the risk for bleeding in myeloproliferative neoplasm is associated with several risk factors. Prior history of bleeding, acquired von Willebrand syndrome, primary myelofibrosis, and thrombocytosis carries a higher risk of bleeding than thrombosis. And patients who are on aspirin may have a higher risk because of the aspirin, and this is true especially in calreticulin mutated essential thrombocythemia. Now, it's complicated to balance the thrombosis and bleeding in cancer patients in general, and especially in patients with cancer and COVID-19, because COVID-19 has severe presentation of VTE. We heard about this during this meeting. VTE is more common than major bleeding in critically ill patients. However, major bleeding increased mortality in critically ill patients. And we heard that there was some issues on that in studies that tried to give maybe a higher dose of low molecular weight heparin in these patients. And we know in cancer patients in general, this is from the Riete, that actually that patients with cancer-associated VTE who are given anticoagulation, the risk to die from bleeding is actually quite high, and even higher from the risk of dying at 1 year from VTE and arterial thromboembolism. Now, patients with cancer-associated thrombosis also have thrombocytopenia quite often. This is true especially in patients with hematological malignancies. And in clinical trials of cancer-associated thrombosis, such as the recent trials with DOACs, the Caravaggio study and the Okusai cancer study, only a minority of patients had hematological malignancies because patients were not recruited to these studies because of thrombocytopenia and other issues. And in severe thrombocytopenia, anticoagulation should be withheld, although prophylactic doses might be reasonable in some patients, even with low platelet counts. Now, what to do in the situation of cancer-associated thrombosis and thrombocytopenia? Retrievable IVC filters may be considered. However, this could be problematic. And of course, the drug of choice in cancer-associated thrombosis, and especially in facing the COVID-19 virus, low molecular weight heparin are the preferred anticoagulant in case of patients with cancer-associated thrombosis and thrombocytopenia, because DOACs are not recommended at this setting. Also for DOACs, there are several limitations in COVID-19 patients. For example, tocilizumab, the IL-6 inhibitor, increased the expression of CYP3A4, or use of some antibiotics used in COVID-19 is associated with interaction with some DOACs, such as edoxaban and betrixaban. And so low molecular weight heparin is the preferred agent. Now, in terms of the viral attachment and infection of the cell, of the endothelial cell or the pneumocyte. As you can see here, this is the virus, and you see the spike protein, and there are several players that you can see here. The ACE2 receptor, the TMPR SS2 receptor, as well as the heparan sulfate receptor, which play an important role. As we saw in a recent study in Cell last December, that heparan sulfate is a necessary cofactor for the SARS-CoV-2 cellular infectivity. Now, heparinase, we know for a long time, cleaves heparan sulfate chains from the studies of Israel Glodowski, and we know that it increases inflammation, that heparinase is pro-angiogenic, is pro-metastatic, and we know from the studies of Yona Nadir from our group that it increases clotting. And in a study that was performed by the MINDS group, and we took part in this too, showed that actually heparinase is a significant player in endothelial cell of age-related VTE model in mice. Now, this brings the issue that high levels of heparinase may exacerbate immune system response and cytokine storm in COVID-19, thus contributing to the severe lung damage during the infection. And this may result in less favorable prognosis of elderly patients or infected with bacteria or viruses, including the SARS-CoV-2. And then there is the issue of intervention and potentially inhibition of heparinase effects by heparins or TFPI2 derived peptide could be an attractive strategy. Now, there are three lines where we can do studies in patients with COVID-19, and this has been mentioned during this conference, in patients who are in hospital, in those who are outpatient, and extended anticoagulation after discharge. But also, and we should consider the potential of local application in patients who are not severe, who do not have a severe disease, in order to reduce disease severity by giving low molecular weight heparin by nebulizer. And I was very much joined the presentation by Sam Schulman on the possibility of using interferon by a nebulizer. Just a few words about COVID-19 vaccines. We just heard from Chian Ai about the different vaccines and the issue of cerebral vein thrombosis. And we have to remember that cerebral vein thrombosis is a multifactorial disease, because it could be related to thrombophilia, especially the prothrombin polymorphism, hormonal therapy, and then acquired factors such as autoimmune disease, antiphospholipid antibodies, or cancer, solid tumors, or myeloproliferative neoplasm. And 2/3 of patients are women. But now we enter the COVID-19 vaccine here as another factor for this disease. The clinical presentation of VITT were mentioned by Chian Ai. I would not go into details here. And also the management, which has been mentioned by Chian. I'm not going to repeat that. So finally, in conclusion, cancer patients are at high risk of COVID-19 complications. Patients with hematological cancer have a worse outcome. Immune response after vaccination is impaired in cancer patients, especially after anti-CD20 therapy. Specific studies in cancer patients are warranted. And vaccine-induced thrombosis is a rare severe complication of adenovirus-based vaccines. And I urge everybody to vaccinate in order to finish this pandemic. Thank you for your attention.
Thank you very much, Professor Brenner, for your very interesting presentation. Dear colleagues, we fulfilled our program, today's program. I think we did a really very good, I hope very useful job. I would like to thank all our participants, and I hope we will have a chance to organize our offline conference in the near future. And I think we are ready to organize that conference on the platform of the Russian Academy of Sciences. Thank you very much once again.
Thank you.
Видите?
Thank you, everybody, really.
Thank you, really.
Thank
Great
you.
moment.
All the
Thank you.
best.
Bye.
Thank you.
Thank you.
It was
Keep
great to
safe.
see you all. Bye.
Thank you.
Finally.
Bye-bye.